on kidney stones by an expert, Dr. Saeed Khan, PhD and Professor Emeritus from the Department of Pathology at the College of Medicine. Saeed is a good friend, but I knew very little about him to tell you. So I was jotting notes before you all came here. But we are good friends other than that, right? Saeed, Saeed is not only Professor Emeritus, he's also Distinguished Professor and has a Lifetime Achievement Award from the University of Florida College of Medicine. He got his PhD here at UF and then went back to Pakistan for about 6 years. And then after that, interestingly enough, he went to Australia, Adelaide for 2 years of postdoc, and then on to Saudi Arabia, where he was a professor in the College of Medicine, Jeddah, in Jeddah, King Abdullah Aziz University. He is very active in the community in Gainesville. Pretty much everybody knows him. He has been the president of the UNA USA organization. He has been president of the Retired Faculty Organization, and also he's on the board of the Mercy Clinic. So you see him everywhere, involved in everything. Saeed has also given talks here on ILR on Islam, right? On the Muslim religion last year, I think.
Yeah, I organized
the whole course on religion for ILR. So he's quite familiar with our system here. Please welcome Saeed Khan on kidney stones. And this is his field of research, and he worked on it at UF here.
Okay. Thank you very much for 1, 2, 3, 4, 5, 6, 7, 8 of you who came here. I'm told that Zoom is active. I was just wondering, I could have just given the talk from my home. Anyway, thank you very much for inviting me. It's kind of nice. Yes. Ooh. Hello. Good? Okay. So anyway, let's start. No, that didn't work. There we go. So I'm sure we are all familiar with it. There are two kidneys. Then there are ureters that connect to the bladder and the urethra. The only difference between male and female is that the male's urethra is different, and also there is a prostate gland there. So the kidney stones can form in the different parts of the kidney. And generally what happens is that the stone may start out in the kidney, then moves through the ureter. And actually, when people feel pain, it is happening when the stone, which was sitting in the kidney, and then it dislodges and it starts moving. So the part is, if you look up at the kidney, there is a stone that is sitting right there. It has a bigger diameter than the tube where it is lodged. So with the pressure of the urine, it's moving, and that's when it starts hitting the ureter epithelium, and then you start getting those blood if there is, depending on the size. Then it ends up into the bladder, which you can see to the right side, and the stone is there. And then, of course, depending on the size, it can be released. And you can imagine it will be, once it is in the bladder, it will be easier to get out through the female urethra than the man. Now, this is one of our urologists holding all those stones. And the stones, there is a variety of them. There are calcium oxalate, calcium phosphate, urate, struvite, cysteine. So if you look up at the, let's say 70%, those are calcium oxalate stones normally are calcium oxalate stone. That means they are formed by mixed action between calcium and oxalate into the system. Then there is a calcium phosphate, which is a very common crystal, but when it comes to stone, that could be about 8 to 10%. Then struvite, which is related to infection, and then cysteine is based on the genetic disease, and so on, which is very rare. And here you look at it. This is the picture of a 20-year-old who drank nothing but sugary drinks instead of water and got 300 stones, those little pebbles that developed because he refused to drink water. He thought, I'm just going to drink, I don't know, anything sugary, something like me, because I prefer some kind of a sugary thing. But these days, you can actually put some Splenda or some honey or something. But this is a picture that was published. And this is even more interesting. Look at the size of that. That was a humongous stone. It was I think it was published, it was found in east of Budapest. And it was, I think I saw that picture sometime in 2009. So the stones, as I'm trying to show, is they can vary in size and shape and what are they made up of. But most of the time, the majority of the kidney stones in people around the world is made of calcium oxalate. And that's what most of these people do study, and that's what I did. I studied calcium oxalate kidney stone formation. The other word for kidney stone is nephrolithiasis. So obviously, nephro means kidney, nephron is the renal tubule, and lithiasis means stone formation. So nephrolithiasis is most common is calcium oxalate throughout the world, not just like in the United States or something, but it is the most common stone, and that's what I studied. And I did both, looked at the kidney stones, induced crystals in the kidneys of rats to figure out what the pathogenesis or the process is that the crystals form. Why do the crystals stay into the kidney? Where do they stay in the kidney? So for that, you have to study in some kind of an animal. So I worked on mice and rats. But then if you want to study something, what happens when, the kidney is composed of little tubes called renal tubules. And all these renal tubules, when the urine is made, it's passing through those renal tubules and going through in different parts of the kidney, and then ends up the urine into the, what they call it, renal pelvis, from there into ureter, from there into the bladder. So when this urine is abnormal, excuse me, then it may start crystal formation. So the crystals can form right in the beginning. Thank you very much, I appreciate it. So if you look at this, these look so pretty, those crystals that are forming. And these are the crystals that I induced in the rats. And the way I induced it just increased oxalate in their urine. And how do you do that? You can do directly injecting solution of potassium or sodium oxalate intraperitoneally somewhere in, and then it ends up into the system. Or some precursors, some that are processed in the liver and then produce oxalate, and then that oxalate ends up into the kidney. And there is a calcium there anyway, because our entire body has bones and all those things. There is a calcium. So if there is, even though both calcium and oxalate play a significant role in stone formation, but because calcium is there, it's the oxalate. So people try to control oxalate in the urine. And so that's what we did. We just gave them more oxalate, as I said, either as injections of potassium oxalate or sodium oxalate, or you can give something like, trying to figure out common word for it. Anyway, the part is this: try to increase oxalate. So the oxalate can be increased through processing in the liver, and then it ends up. So this is how I did. And if you look up there, there is CAP, stands for calcium phosphate. So those tiny crystals, they were from the urine of a rat, calcium phosphate, and all the others are calcium oxalate. Calcium phosphate, and these are all calcium oxalate. But if you look at these crystals, these dipyramidal shape, or this crystal right there, because the oxalate crystals can be of two types. One is called calcium oxalate monohydrate, and the other is calcium oxalate dihydrate. So this thing, these are calcium oxalate dihydrate, and here too there is a calcium oxalate dihydrate, but the rest of them, these platy crystals, are calcium oxalate monohydrate. These are all calcium oxalate monohydrate. Interpenetrant, we call them interpenetrant twins, because they crystalline form and then continuously grow, twinning one crystal into another crystal. And these round-shaped things are calcium phosphate, which is actually very common in the urine if you see it. And if you, for example, some common foods like, say, spinach even. If you eat a spinach, it has oxalate in it. So it will end up into the urine. And if you look at your own urine, you can find calcium oxalate crystals in it. But they're enough that you drink a lot of water. And actually, the very interesting thing is the oxalate has to come into the urine. So if you notice it, whenever you are getting some spinach, it is made with some cream or sour cream, milk, something. There is a calcium in there. So the oxalate of the spinach binds the calcium of those cream, and then what happens is it goes through alimentary canal, does not go into the urine, it comes out in the stool. And that's the whole idea, that when you're making a spinach, if you look up there with the spinach, there may be some cream in it, the purpose of the cream. And sometimes people say, when English and almost all of us drink tea, tea is very high in oxalate. You put milk in it. It makes crystal, and it ends up again into the stool rather than into the. So that's the part about how these different type of diets have effect, and putting it together with cream and milk helps. And these are actually stones from the humans. This, and I fractured it to show that, okay, you see this layering. And these are, you can look at it and you can say, okay, these look like those plate-like crystals of calcium oxalate. And these are round eye structures are calcium phosphate. So this is a stone, and fracture it, and inside, when you do a scanning electron microscopy, you can see it. And also, the scanning electron microscope is attached with energy dispersive X-ray microanalysis. So you can look for calcium, and you can look for phosphorus. So when you have calcium and phosphorus together, and you can tell what the proportion is, the two, you can say, okay, yeah, it looks like it has calcium and phosphorus, it most likely is a calcium phosphate. But when you see crystal, and you don't see any P coming up, and there is only calcium, and looks like that calcium oxalate. So you can identify. So many times when if you have issues with calcium oxalate, then they are looking at the urine. And in the urine, there are quite a few different methods to identify them, particularly the structure that I showed you. You see this dipyramidal structure. It's very unique. And if you see that in the urine, you say, oh, this is calcium oxalate dihydrate, period. And if you see the other kind, then you have to do the analysis. And there are quite a few different types of chemicals that you can do to define it. And here is, I just love this picture because you can just see this thing that in the middle, and then you look at the layers. And I had a picture where I put a donkey over here and a person, and you can just see climbing. So you can imagine that the stone may have started something like this, and then continuously by addition of crystals, and these are calcium oxalate monohydrate crystals, they keep adding, and through months of addition of calcium oxalate crystals, it becomes a stone. So the crystals are there, they keep adding to pre-existing crystals, and that's how things increase. Oh, I forgot. Now, the very interesting part is this. When you look at this, and this is all crystal. So I decided, okay, let's see, because we all know the urine is not just crystals. Urine has all kind of other stuff that's coming out. And mostly there are a lot of proteins and carbohydrates and lipids in the urine. And the old thinking was, and it's still people think, that those proteins, so the crystals are like bricks. And those protein material is like a mortar. So you're adding, you put the crystal, there is a protein, another crystal, another protein layer, another. And that can be considered two ways. One is that, okay, this protein layer is helping stone formation. My interpretation is, no, body is responding, stop the growth of that crystal. So it puts a layer. But those proteins can work both ways depending on what the pH and other situations are. So then what I did was I took it, this type of stone, and I just decalcify it. Got the crystals out completely. You can put it in the acid. You can, if you don't want too quick and you want something that you can preserve it, you put it in a solution that has some fixative in it, like a glutaraldehyde or something that keeps the protein in its place. And if you look on this side, see this thing? The layering? This whole area, the crystals are gone. So the part I'm showing is the reason this stone, there is a lots and lots of what is called, this is called organic matrix. It holds the thing together. And even though when you look up there, it's extremely pervasive, it is there all the time. But by weight, it will be anywhere between 2%, the weight of the stone. But when you look at this, how involved that thing is, and that's what a lot of people try to study that thing. What happens if we try to break down the protein and then the crystals will disintegrate and the stone will disintegrate if we go just get rid of that protein layer. So there are a lot of people who have tried that method to look up. And look at this thing. All this thing, whatever you are seeing there is scanning electron microscopy. This is after I have demineralized the stone. This is all organic matrix. And reason I'm trying to show you how intimate the relation is between the mineral and its organic content. That even though I demineralized it, you see, you can actually see this plate-like structure of calcium oxalate monohydrate. You can see this layering. And here, if you look up there, you see the pyramidal shape? Even that thing has got layering. This is a calcium oxalate dihydrate. This is calcium oxalate monohydrate. And this round structures. Remember I showed you calcium phosphate, they're kind of round structures. This is all calcium phosphate, but these are the remains which are organic material. So let's move on. So what are the symptoms? So the first thing is nausea, lower back, pain when you pee, fever, chills, urge to pee a lot, bloody, cloudy, or foul smelling urine. So these are, and the funny part is this, none of them are very specific because people may feel nauseated by something else. People may have issues with the prostate, to be having issues with the peeing for the man particularly. But the bloody or cloudy or foul smelling is one of those rare things. So now let's think about what causes the crystallization. So I don't know whether any of you did those things when you were kids, but when I was a kid, we will have water, we will put sugar in it, and we'll keep adding sugar. And then you remove it from the heat if you're heating it, put a little stick in it, and the crystals will form on top of it. And then you can just tuck them, you know. So what is the same thing happening here? There you are increasing the amount of sugar, kept increasing. and the thing crystallize. And that stage is called saturation. When the solution is saturated with things, then it crystallizes out. And then, but the part is this, when it is there, it can also go down, the saturation. But there is a point called supersaturation. When it reaches that point, then there is only outcome is crystal formation. So this is what is here, that this is kind of a stable where you put the sugar in there and it dissolves. Just like when you make any kind of a sugary drink, you do it, becomes sweet. Then there is a reason called metastable, that what happens is, if, as I mentioned it, in the sugar solution, you put the stick in crystal form. The same thing is here. If you add something to it, in this state, it will make crystals. And then there is this spontaneous crystallization. So when people go to the urologist or nephrologist and they look at the urine, they also look at what are the things in it, and how much there are, and what is they can calculate something called relative supersaturation. And I was fortunate to work with someone at this College of Medicine, Department of Urology. His name was Birdwell Finlayson, who developed a model, a equation that will look at everything that's in the urine and put it in this formula, and they will say, okay, how much chance there is that in this urine a crystal will form. And amazingly, that thing is still, he developed what, 50 years ago or something? And people have been trying to improve it. But if they try to improve it, then the gold standard is still the equal, the thing that he developed. They have to prove that this is better than that. So Dr. Birdwell Finlayson, he was a professor of urology here. He was a surgeon, but also he was a biophysicist. He did his PhD and then went to medical school. And so I was fortunate to work with him, so to understand a little bit. And I mean, he was also one of those people, I don't know, I'm sure many of you, even those who were fortunate enough not to have a kidney stone, know that there is something called shockwave lithotripsy, that they break down the stone into smaller pieces, and those smaller pieces are released into the urine. So one of the first experiment on that was done here in the dogs. And when Dr. Finlayson asked me, do you want to participate in this experiment? I just couldn't do it. I just, the dogs, I mean, I work with the rats and mice, and I look at the rat's eyes. I don't see anything there. So I remember this thing the first time. I mean, I did my PhD in botany, plant. Didn't want to do anything to blood. And here I come as a postdoc, and I have to work on the rats. And rats have blood. I don't like blood. It comes out when you do the surgery. So the person who was training me, he said, Saeed, look in these eyes. And I looked in the eyes of the rat. And he said, these rats, what are called Sprague dolly rats, their main purpose is to be used in experiments. And from then on, but dogs and cats and monkeys, no, their eyes, I just can't handle it. I mean, there are people, I go to the College of Medicine, and they have the whole animal thing downstairs, and they have two accesses. One is access to that place was You go down, but you had to go through where the people in neuroscience were working on the monkeys. No, I won't go. I'll go to the other end, take the elevator down. It's so I didn't take part in that. But what I'm saying is that a lot of experimental work was done at the University of Florida, and Dr. Finlayson was one of the pioneer in this area. And I was fortunate to work with him. So here we go. How kidney stones, and again, because I worked on calcium oxalate kidney stones, so whenever I'm talking to you, I'm talking only to calcium oxalate. There are other kind of stones, as I mentioned it, but I'm talking about calcium oxalate. So here it is, kidney stones. When you have excessive oxalate, then there will be crystal, and the crystals grow. And as I was showing you, crystals can grow, and they by twinning, by adding more crystals to it, and the word is aggregation. So the crystals, even when the crystals are formed separate from each other, they can aggregate. So one crystal is not a stone, 100 crystals is not a stone, but as soon as you go beyond that, size becomes bigger than the diameter of the opening in the renal tubule. Then it starts as it stops somewhere. And then it may start a stone. Yeah, here. Urine. And these. And what happens is, as I was showing you earlier, that organic matrix. And so I don't think, actually, I even didn't realize it, that throughout our kidney is the cells are dying and new cells are being formed. So what happens to those dead cells? They end up into the urine. That's how we are passing those crystals. And what are those cells made up of? Their membranes have lipids. The inside, there's proteins. There are all kind of stuff. And that's what makes up the organic matrix. But lipids and proteins have very special thing, that lipids can act as a nucleator. Just like I remember I told you, when you have a sugary solution, you put something in it, crystallize. The same way in the urine, if it is not totally high saturated, but if there are membranes coming out, those membranes act as a nucleator. And then those crystals can come together and they aggregate. And the whole thing is that those aggregated crystals, as I mentioned it, if the aggregate is bigger than the diameter of the renal tubule where they are, and here there is also a very interesting thing. When renal tubule starts, the diameter of opening is smaller. And then you keep going through it, and it becomes bigger and bigger and bigger. So depending on where the crystal is formed, if bigger aggregate is formed in the beginning, it will stay there. Because the diameter of the tubule is small compared to the crystals. And sometime I think even I have gone to getting X-rays done, and I have crystal deposits in earlier part of the kidney. But those are not stones. Those are crystals just deposited because they could not move. So, and there is a difference. There are two terms, nephrolithiasis, as I said. There's something other than that. It's called nephrocalcinosis. So if you go And so nephrocalcinosis is crystal deposits which are not going to do damage. It's there. Kidney is taking care of it. But nephrolithiasis is when they become kidney stones. So here we go again. Stone in. Now, the part is this, that our body knows what's going on. I mean, things are happening. So there is, on the one hand, there is something which helps in crystal formation. And the reason is because that is what metabolism is. There are metabolic things happening. Calcium is going to be there. There's oxalate is going to be there. There are membranes are going to be there. So there's one thing which actually promote the crystal formation. On the other hand, the body knows that it's going to happen, so they have something called inhibitors. And the most common inhibitor is citrate, and that's why if you have stones of calcium kind, majority of the time, they will give you something which has citrate in it. And what does citrate does? There is a citrate ion in the urine. There's a calcium ion in the urine. There's an oxalate ion in the urine. If those things are there, calcium will bind with citrate, not with oxalate. So if it binds with citrate, then that does not crystallize. And you can release that, and oxalate stays free and it's released. Then the other thing is magnesium is a different thing. Magnesium, and I will tell you an interesting story about that. So the magnesium, if it is in the urine, it actually binds with oxalate. So magnesium oxalate, again, there's no crystallization. So sometimes those are the two things, but the most common thing is that when the physician will prescribe something to do with citrate in it, and some people just say, just drink a lot of lemonade without sugar. Lemonade. Because I remember there used to be a Dr. Thomas here. I don't know whether anybody knows that. Professor Thomas was there. And he was telling that whenever he will see stone patients, and you tell them increase your urinary volume, and they'll come back, nothing is happening. It turned out to be they were drinking what? Sweet tea by increasing volume, and the tea has oxalate in it. So he said, no sweet tea, just plain water. Use water to increase your urinary volume, and just add some lemon juice to it. So it's interesting. And that magnesium thing is very interesting because at one point I did get a small grant, looking at the effect of magnesium using my rat model. And so his whole thing was dates, the dates that we eat, they're very high in magnesium. And so I remember this thing at they have conferences for urologists, nephrologists, and all that. I went to the urology conference. I went to his booth, and he sent me beforehand, come and have a date with my sister. Because sister was behind the booth. She was like 65-year-old. But it was so funny that I'm sure this card got a lot of attention, and a lot of people went there to have a date with his sister. Okay, so that's the whole process. That was, my wife made this thing for a presentation for me at, I don't know, at one of the conferences, and sometimes I still get this, that, can we get that slide? And the thing is this, if you look up there, you see this oxalate sign is small here, bigger. You see, this is, I don't know how much familiar you are, this is the one renal tubule, and the urine starts forming somewhere here, which is called glomerulus, and this thing is a proximal, this is a tubule right there. This is the proximal tubule. Then there is, this part is called thick ascending limb of the loop. Now, if you look right here, coming, all of a sudden you see the thickness, this becomes thin, and then it becomes wider. I'm talking about this, the thickness or the opening of the tubule or the diameter of the opening. And so oxalate starts, but then there is a concentration happens and it becomes high. And I'm just showing oxalate, but it could be every other thing because the urine is being concentrated. What happens is the body wants to keep a lot of good stuff which is in the urine. They want to take it back. There's a lot of stuff. So the urine starts getting concentrated. But the other effect of it is that the ions like oxalate, they become, the solution becomes more saturated with those ions. And so I thought that will give you some idea. Okay, so now just a little bit, the most common stones that we do not know, I think if you go to any medicine thing and if they use the term idiopathic, what it means is we don't know how it happens. That is idiopathic. So the most common, as I said, is calcium oxalate, and it is idiopathic calcium oxalate stones. I'm going to tell you, there's something called Randall's plaque. And that is but this part, that crystal idiopathic calcium oxalate stones develop attached to Randall's plaque, which are subepithelial, that means under the epithelium, deposition of calcium phosphate. So the first layer that starts out is calcium phosphate. And then that becomes the basis for attachment of calcium oxalate crystals. And here is another diagram showing all this. So one way of doing is this, that you see this tube going through. Again, if, as I was telling you, if you look at the proximal tubule, you see that the space there is bigger than here, it's narrow. Then it becomes bigger again, and it comes out. So these, as I said, there are crystals that are calcium phosphate. So sometimes calcium phosphate is deposited not in the tubule, but between the tubule. So these round structures are calcium phosphate. And then they deposit and make the Randall's plaque. And what happens is this thing is being formed right under the epithelium, which is covering the kidney at that place. But if you keep adding these crystals, what will happen? It will stretch. And after stretching, it breaks open. And there are a lot of different molecules that are involved in that breaking apart. And then these things, which is under the, like a skin type, they become exposed to the urine. and then crystal deposit on top of that. On the other hand, this is crystals start forming. This is another way of doing it. The crystals are forming in the tubular lumen, and then they aggregate at the tip of the tubule, and the stone forms. So here, two ways of making it, here and here. So now the part is this: if the urine is too supersaturated, of course, there are a lot more crystals are going to form in there and make a stone like this. But if there's not that much oxalate or something, then what happens is the crystals of calcium phosphate forms not in the tubule, outside the tubule, and the stone is formed when they become exposed to the urine. And here are some pictures from my experiment with the rats. And you can see when I'm talking about the space and the crystal size. You see, this is a tubule, and this is the space, and these are the crystals. So in here, these crystals aggregated and also attached to these structures, and they become lodged in the tube, right here. But in here, this crystal, so this crystal can pass out through the urine because it's one crystal and it's moving, but this crystal stays there, and it is kept by all kind of biological material, or the crystals can also stay there by attaching right here. And once they attach, other crystals that are coming down from the top, they attach to it, and they will become aggregates and block the tubule. So this is a good friend of mine has made this thing very simple, trying to show a stone thing, that when you look at the kidney stone, he gave this example of, you see the stone, but you don't see that this is attached to something else under there. So this is like a tree, and this is the root. And this is the epithelial surface of the kidney. So idiopathic stones formed on the Randall's plaque, which is made up of calcium phosphate. And here is some pictures from my urology friend. They were trying to remove the kidney stones. And you can see these are the stones. And this is on the surface. And here you can actually see kind of a basket that they're attaching to it to pull the stone out. So this is the tip of the urinary tubule. There's a crystal deposit there, or a kidney stones, and they are trying to pull it out. That's how the surgery is done. So now coming down to what should be done, or what do the physicians or urologists or nephrologists do, depending on the type of a stone. So if it is a calcium stones, as I mentioned, citrate, or diuretics, so increase the urinary volume enough that the crystals that form can pass out. Uric acid acetone, which is something called allopurinol, which stops crystal growth in that, but they also give potassium citrate. Struite is an infectious stone. So they give antibiotics and other kind of antibiotics mostly. And cystine stone is a genetic thing, and they have a very specific drug that they give, and also addition. Potassium citrate is a very common. So this is a very simple, the whole thing, that kidney stones, hard deposits in the kidneys, common causes, not enough water, high salt, too much animal protein, sugary drinks, excess calcium and uric acid, and also genetics. history. What it is, drink more water, reduce salt, cut sugary drink, eat balanced diet, don't hold urine, stay hydrated. So if you're speaking and you have to go to the bathroom, you better go. Drink water. Thank you.
Questions? Thank you for a primer. Kate.
Well, now I have three. Because in your prevention list, you didn't say, reduce eating spinach. And what I want to ask about the nutritional stuff is spinach, but also would it be all leafy greens like Swiss chard and beet greens and turnip greens containing a lot of oxalate?
I mean, there is a whole list of the things that, for example, okra. I love it. It has a lot of oxalate crystals in it.
Okra? Oh, okay.
But I love it.
too.
But you cook it. Basically, the idea is you want to make it so it may be delicious, you like it, but add some cream to it. Drink a lot of water. And that's why the drinking water is, I mean, if you go Google it, oxalate,
Okay.
and they will give you literally, you can eat nothing then. Because everything has some kind of oxalate in it.
We are, told that leafy dark greens are really good for us. So
Yes.
if we don't have a problem, it's not a problem.
Yes.
And also on the prevention list, you said sugar, because the 20-year-old, the sugary drinks.
Yes.
I was going to ask if oxalate sugar,
I
a lot
think
of sugar produces oxalate.
No,
No.
that doesn't, no. It's, I don't actually tell you the truth, I don't know the answer for that. But sugary drink has something to do with, because they will always tell you, don't this. And not only just that, not sugary drink, even diet drinks. Simple, plain water is the thing to go.
I really enjoyed your talk. Several questions. Is green tea different than regular tea in terms of its content of oxalate?
It's very interesting because I remember reading a paper, actually I was reviewing a paper on the subject of oxalate content of the tea from different regions in China. And tea grown in different places had different contents in it. And sometimes the thing is just like when you're drinking regular tea, you put milk in it. But many times when you're drinking green tea, you add some lemon juice. So you're increasing citrate in it. That citrate is, as I mentioned it, is a very interesting thing. And maybe I never thought of it seriously, but in Middle East, they are the biggest, I mean, the stones are very common in Middle East. And if you look at the different parts of the world, the UAE and Saudi Arabia, the two reasons, it's hot. That means their water is coming out through the pores rather than going into the urine. And the second is they eat a lot of meat too. The meat has got, in the end, ends up as particularly some part of the meat that have purines, which can convert later on. So there is the eat, and but again, for them, they eat dates, and the dates have magnesium. Date, the fruit, is high in magnesium. Yeah. So there is a whole lot. I think when God was doing all those things, he also gave them dates. Okay, if you are doing this, eat dates. Yes.
Thank you for your talk. I was wondering, I didn't know about the organic matrix in the kidney stones. Do they have a role in shaping the various, outer shape to make it
Yes,
easier to
yes,
pass?
yes. There is a lots and lots of studies on different proteins because, I mean, when you're looking at the urine, as I mentioned it, the kidney is sloughing off a lot of epithelial cells. New things are forming, old is going away, coming out, releasing it into the urine. Some of them are protective and some of them are not. And so they have, and in response to high oxalate or exposure to calcium oxalate crystals, people have studied, they take the cells that line these tubes, renal tubules, epithelial cells, just like skin is here, kidney inside, there is epithelium. They can grow those cells and then expose them to high oxalate and calcium oxalate crystals, and then see what is the response. So there are a lot of proteins are being produced. And in there, I mentioned it, there's something called osteopontin, which is very, very big in this area and actually in all the calcification, whether it is bone or heart or everywhere. So depending on the concentration, they can change the shape. Some people have the opinion that calcium oxalate monohydrate are worse for making kidney stones than calcium oxalate dihydrate. And they have shown that if a specific kind of proteins in a specific concentration is there, then they will make dihydrate than monohydrate. And so these are all studies. It's nothing, there's a lot of experimental work, but the human work is not there. But again, the thing is this, that yes, those proteins affect the type of crystals can form, or the shape of the crystals, and also aggregation of the crystals.
I take calcium citrate and magnesium citrate pills. I want to know if that's good or bad for stones. And also, I eat a lot of kale. Is that bad?
I think you should ask your physician that question. Kale, I mean, I know that a lot of people say it's good for you. So, but again, when it comes to the stone thing, I think I'm not going to advise you, I should say.
Yeah, sorry.
Is the action of citrate in terms of preventing oxalate stones, is it pH dependent?
It should be, yes.
So it depends on a alkaline urine?
I'm forgetting that the problem with calcium oxalate monohydrate is it's like calcium phosphate, you can say, okay, it should be alkaline pH. But calcium oxalate is does not care too much about the pH. So that's, yeah. But citrate is good. Citrate is good. And actually, I mean, a friend of mine in Thailand, he has developed this whole thing with citrate in it. He doesn't want to tell anybody because he's trying to sell it and he's doing very well on it. But a lot of citrate compounds are good with I mean, it seems to me like even if you look up there, potassium citrate, even with the uric acid stones, people give them. So that's a good thing.
What about calcium? We are all told by our doctor to take more calcium, more calcium. And then people who have kidney stones are told not to take calcium. But it's really the oxalate, right? What's the relationship between taking calcium and getting kidney stones, in other words?
Controversial. That's all I can say on the subject. That there was a time when basically even I remember it in my like 50 years of going to conferences that calcium was supposed to be bad, but then it turned out to be basically calcium, as I mentioned it, it can bind in the diet. Dietary calcium can bind the oxalate in the diet. It goes. So yeah, that's and then the whole idea about the calcium in the stone is people can write this, do this, but again, the calcium in the diet, because when you're taking as a pill, I think it ends up going into the dietary thing and it can bind up. So it's, but again, I think it depends on your urine, that it has to be tested, what is going on in there.
Okay. Another question I had was because of that organic base matrix. Are there studies going on to actually treat kidney stones by treating the base, the organic base, say with enzymes or something to dissolve the base so that the crystals can then be passed?
Yeah, I mean, there is a whole group of researchers, but I don't think there is any clinical data on that, whether, but because I think what happens is the kidney stone disease is such that it doesn't give you anything other than once you have a kidney stone, then you get the pain. The whole thing process has already happened by the time you get the stone. And then they can go there and remove shock wave lithotripsy. And generally, that person may have another kidney stone in maybe 4 or 5 years. So the physicians and the urologist, and now there's a big role on the diet that they will tell you, do this. Dietary changes. But what happens is, once the kidney stones pass, after 4 or 5 months, patients will stick to that thing. And then they forget that they had a kidney stone. And then 5 years later, they may have another one. So, but there is still kind of nothing totally resolved that whether it is the calcium taking is good or bad. But again, the calcium, particularly with the osteoporosis and all that kind of stuff, that may be important. But yeah.
Now, I know you showed a picture of a 20-year-old with hundreds of stones, but in actual life, is there a relationship between age and development of kidney stones? In other words, is the incidence higher in the older population?
Depends, because as I mentioned, there is a genetic component. So if you have a disease in which liver is producing a lot more oxalate, that can show up even before birth, because it's called primary hyperoxaluria. There's genetic issues. They will make stones, and they keep making stones again and again. But normally, it is used to be that somewhere between 30 and 50, there is a whole data on it. And it used to be that it was a male who will have this, more male will have kidney stone than female. But I'm told that now the females are coming up. like in every other respect.
All the people I know who have kidney stones, they're all women. Yeah. So.
But those, do they have a true white stone?
I don't know that.
There is an infectious stone is very, because the infection can happen in women more common, I guess. And so urinary tract infection,
Right.
and then it can be stones, which are generally true white stone.
Yeah.
But, and I remember the friend of mine was telling me that in Europe or somewhere, in England, there are a lot of younger women, they are having kidney stone that they didn't used to. So there is a change in the diet, I think, or living conditions, or anyway, yeah.
Yeah. Okay. Any other questions? Not? Thank you very much, Saeed. It was very informative and interesting. Thank you so much for doing this.
Thank you.